I am Becky Klemme. I'm a nurse practitioner. I work with the Avera Medical Group, liver disease in Sioux Falls, South Dakota, and I've been doing hepatology care there for over 10 years. Today, we're going to talk about lifestyle management for patients with metabolic dysfunction associated steatotic liver disease. What is MASLD? It's fatty infiltration of the liver in patients who do not drink alcohol. They might be overweight or obese. They could have type 2 diabetes or 2 or more metabolic dysregulations. This leads to fatty infiltration of the liver. You can start with simple steatosis, as the graphic shows, which can then progress into steatohepatitis. We worry more about steatohepatitis because it's an inflammatory kind of fat. If it sits in the liver over time, can start to cause inflammation, damage to the liver, and can cause fibrosis, which can then progress into cirrhosis. Once patients develop advanced liver fibrosis or cirrhosis, they're at higher risk for developing liver failure or hepatocellular carcinoma. So it's important to identify patients with fatty liver disease early so you can catch it in the early stages to prevent them from progressing into the more advanced liver disease. So we'll go through a patient case today. Our patient is Albert. He is 65 years old. He's referred to the clinic with elevated liver enzymes. On his ultrasound, he has increased echogenicity consistent with hepatic steatosis. He's been following with his primary care provider, and his liver enzymes have been elevated about 1 to 2 times the upper limit of normal for the past 3 years. He is a Hispanic male, BMI 29, which would actually put him into the overweight range. The cutoff for obesity is a BMI of 30. He stopped drinking alcohol in his 20s. Medical history includes type 2 diabetes, hypertension, and hyperlipidemia. For key exam findings, he does have abdominal adiposity, but no stigmata of advanced liver disease. And when we talk about stigmata of advanced liver disease, things that I'm kind of looking for are jaundice, fluid retention, muscle wasting, weight loss, spider angiomas, things like that. He doesn't have any signs of that. Listed under labs, you've got his triglycerides, HDL, his A1C of 7.2, and then that ALT 1 to 2 times the upper limit of normal. Important to note here that he has been evaluated for other causes of chronic liver disease, and those have been ruled out. That's an important step when you see a patient with elevated liver enzymes and fatty infiltration of the liver. You want to make sure that you're not missing hepatitis C or iron overload or other causes. So for this patient, we can diagnose him with metabolic dysfunction associated steatotic liver disease. This used to be known as non-alcohol related fatty liver disease, with the name being changed about a year ago. So the next step in his care is to determine if he has any underlying liver fibrosis. So the stage of scarring in his liver will greatly impact the further care we provide for him. So it's important to know where we're sitting. The first thing we like to calculate is the FIB-4 score, and this takes into account the patient's age, their ALT, AST, platelet count. For this patient, his FIB-4 comes back at 2.22, which puts him at indeterminate risk for advanced liver fibrosis. So the next step would be to obtain a FibroScan. A FibroScan is a test we do in the clinic, which uses a sound wave to assess the level of liver stiffness, which correlates with the level of fibrosis. His score comes back at 6.7 kPa, which puts him at low risk. So in this case, he doesn't have advanced liver disease, so our treatment recommendation for him is going to be lifestyle modification, metabolic disease management, and then follow-up of repeat non-invasive testing. So a lot of times I'll tell patients we're looking down the road. Your liver is okay right now, but if this fat stays in your liver over time, you could look at progressive fibrosis, which we want to prevent. Lifestyle modification, the first thing I always tell people is no alcohol. Even in this patient's case where he doesn't drink, I would just still go through with him the importance of completely avoiding it. And then he wants to follow closely with his primary care provider make sure that his type 2 diabetes, his blood pressure, his cholesterol are well controlled. Cardiovascular disease is common in patients with fatty liver disease. So you also want to touch on cardiovascular risk modification. If he smokes, he needs to stop smoking. He needs to work on weight loss, exercise, and have periodic cardiac screening with his primary provider. The risk factors and pathogenesis for fatty liver disease. So it's not been fully elucidated, but insulin resistance is likely a key mechanism which leads to hepatic steatosis, along with oxidative injury that can result in a necroinflammatory component of steatohepatitis. Other factors like hepatic iron, gut hormones, antioxidant deficiencies, and intestinal bacteria have been implicated in the pathogenesis of MASLD. They have identified genetic mutations that can put people at risk for fatty liver, which are identified there. So genetics in combination with diet, increased saturated fats, fructose, dietary fats can contribute to that fat in the liver, the steatosis, which can then develop inflammation, progress into steatohepatitis, the more inflammatory fat, which can then lead to cirrhosis. So the pathogenesis again of MASH and MASLD, the obesity pandemic, as rates of obesity have raised, rates of MASLD have increased as well. Obesity being defined as a BMI of 30, about 800 people worldwide are considered obese, and about 42% of people in the US. Obesity also increases rates of type 2 diabetes, high blood pressure, cardiovascular disease, sleep disorders, osteoarthritis, increased risk for premature death. So as those rates have gone up, MASLD has gone up as well. Type 2 diabetes and MASLD have a converse relationship. Diabetes is an independent risk predictor for MASLD severity. So if a patient has MASLD, they have type 2 diabetes, they're at higher risk for developing more advanced liver fibrosis and complications. And also patients who have MASLD have an increased risk for developing type 2 diabetes. So mainstay of treatment for MASLD is going to be weight loss and diabetes control. Management of NASH. So you want to have a balance between nutrients and energy is crucial in the development of MASLD and MASH. And that central obesity, again, is a major promoter of insulin resistance and pro-inflammatory signaling. Lifestyle modifications. So obesity is a complex disease with interactions of environmental influences. So we're talking like calorie-dense food, sedentary lifestyles, along with known obesity risk genetic variants that increase people's risk for gaining weight and their ability to lose weight. So we know that the efficacy of diet and exercise treatment can be impacted by these genetic polymorphisms. So when we're looking at our patient, upon questioning Albert, he explains that he eats a traditional Cuban diet consisting mostly of rice, beans, pork, corn, beef, and plantains. How can we best discuss diet with our patients, and how do we tailor our dietary recommendations to include cultural preference and food accessibility and socioeconomic status? Kind of a complex question, and this will vary greatly based on the type of clinic each person works in. But again, just having culturally sensitive care, good communications, translators available, and then tailoring your recommendations to incorporate traditional foods along, with healthy eating principles, involve family members. I like to connect people to dietitians when I can, and then also asking the questions about food accessibility and employing or engaging the social workers when appropriate too. So for lifestyle modification, we look at dietary change and exercise. This has been the mainstay of MASH or MASLD treatment. Resdifra or resmetirom is a new medication which is on the market for patients with steatohepatitis and stage 2 to 3 fibrosis. So we won't talk on that too much today, our patient being in that stage 0 to 1 fibrosis. But again, diet and exercise have been our mainstays of treatment. And then we have found, or they have found, that weight loss is directly linked to improved histologic outcomes. So if a patient can lose 5 to 10% of their body weight, they can resolve steatosis, MASH, and even exert anti-fibrotic effects, meaning that the fibrosis or scarring in the liver can improve. So weight loss is really helpful. Weight loss goals. So in general, 5% body weight loss in a patient who's obese can reduce blood pressure. 5 to 10% body weight loss can decrease the hemoglobin A1C and improve the HDL. A 10 to 15% body weight loss, improving hepatic steatosis and sleep apnea. And if a patient who's obese can lose above 15% body weight loss, that can result in lower rates of all-cause mortality and improved quality of life. So when counseling patients, it's important to take a patient-centered approach, have them set a personal weight loss goal. It should be individualized based on their preference, their body composition, their comorbidities, and to be, patient-centered in your approach, asking permission to discuss weight, providing privacy for when they're being weighed and that type of thing. For weight loss approaches, there's different approaches you can take. But their evidence-based obesity treatment combines interventions, including behavioral interventions, nutritional approaches, physical activity, and then moving into pharmacologic or bariatric procedures. For the purpose of our talk, we're just going to cover the first 3. Pharmacologic or bariatric procedures would be indicated in patients with a higher BMI, or a patient, again, just in the overweight range, or in a patient with more advanced fibrosis. Behavioral interventions refer to those kind of outpatient, community setting, primary care, commercial programs, the weight loss clinics, the Weight Watchers. They have group, individual, technology-based support with education, peer support, coaching, goal setting. Those can be helpful for patients if they're, lacking information about the type of diet they should use and that type of thing. Those have shown to be beneficial. A lot of times can link people to dietitians as well. Nutritional interventions would refer to restricting or eliminating certain foods in order to create a calorie deficit. This is generally going to be 1,200 to 1,500 calories a day for women and 1,500 to 1,800 calories a day for men. Mediterranean has been the most studied and most found to be beneficial for fatty liver disease. Again, calorie restriction is the mainstay to weight loss. Try to promote ketogenesis. Again, taking into account differences in genetic predisposition or personal responses to a specific diet, but that Mediterranean diet is supported as the recommended primary lifestyle intervention. Physical activity. So what I recommend to patients is 150 minutes per week of moderate intensity, or 75 to 150 minutes per week of high intensity resistance training 2 to 3 times per week. And then if patients, once they get to their goals, if they exercise 200 minutes per week, is associated with a better maintenance of weight loss. However, weight loss alone is not an effective weight loss tool, exercise alone. If a patient adds exercise but continues to eat the same diet, their weight loss is only going to be about 1 to 2%. So I do encourage weight or exercise because it's good for the heart, can reduce abdominal adiposity, can decrease insulin resistance, is good. Yeah, good for a lot of things, but it isn't an effective standalone weight loss tool. High intensity interval training has not been shown to be effective, and resistance training versus aerobic training, one hasn't shown to be superior to the other. Looking at our clinical case, Albert returns for follow-up, and with no improvement of labs. He admits that he has not begun any exercise regimen, but he has been trying to cut out soda. How do we work with patients to create behavior change? So one thing that I try to use is an evidence-based counseling strategy called the 5A framework. It's where you assess, advise, agree, assist, and arrange. So the assess stands for, asking permission to discuss weight, assessing for obesity-related comorbidities, screening for social determinants of health, housing, food security, and then reviewing their blood tests and looking for obesity and cardiometabolic risk factors, and also kind of finding out what's your patient's goal. Then we move into advising, which would be discussing fatty liver, obesity as a chronic disease, the health risks and the benefits of weight loss. And then agreeing on specific, measurable, attainable goals, changes to diet, physical activity, sleep, stress management. And then assist would refer to sending them to those intensive behavioral management counseling, looking at weight loss medication, surgery, or having just a close follow-up appointment so you can ensure that they're sticking with goals as closely as they're able. You can also use adherence validation. So there's the exercise and diet adherence scale, or EDIS. It's a voluntary scale questionnaire at baseline, and at 6 months, there's 33 criteria checked to monitor daily exercise and calorie intake, just a kind of helpful tool to follow up to see if they're actually following the recommendations provided. Okay, and I think that's kind of all I've got. There is some additional information here from Madrigal. Are there any questions?